Hi class, welcome to Unit 3 where we're going to discuss EKGs and how to read EKGs. First, I want to talk a little bit about the function of the heart and a refresher of the blood flow in the heart. So the heart is a structure that's composed entirely of muscle, and it's a muscle that works to pump, and it pumps oxygenated blood and perfuses the body, organs, and tissues. There are 4 sets of valves, or 2 sets of valves for total, that we want to be familiar with and be able to locate in the heart and know that they work in coordination with each other. And that's what propels the blood forward through the chambers of the heart and out of the heart, either to the lungs to pick up oxygen or to the body to perfuse. On the right side of the heart, there's the tricuspid and pulmonic valves. On the left side, there is the mitral valve and aortic valves. When we auscultate the heart, we hear a lub-dub, also known as an S1 or an S2. So S1 is the lub, and that's the ventricles squeezing during systole. And then the dub is when the ventricles relax and the atria fill during diastole. Everything should work in coordination, and the right and left valve pairs should open and close simultaneously. It's of special note that the left ventricle is the most important pumping section, and the left ventricle is usually much bigger and stronger than the right. And you also need to know that electrical conduction is what is driving that pumping coordination, and that electrical conduction is why we can use an EKG strip to see what the conduction of impulses are through the heart, and that's what we're going to talk about more. But before we get to the electrical conduction, I wanted just a refresher on the flow of blood from the unoxygenated side of the heart to the oxygenated side, and to think about where things are going to back up if someone has like pump failure, otherwise known as heart failure. So on the right side, problems are going to back up to the body. So you're going to see things like dependent edema, jugular vein distension, abdominal distension. You could have some generalized weight gain, swelling of the hands and fingers. On the left side, you're going to have it, if there's a left-sided of the heart pumping problem, that's going to back up to the lungs. And if it's really bad, it's going to actually back up to the lungs and the right side of the heart. But the signs and symptoms that we see with left-sided problems are things like pulmonary congestion, shortness of breath, fast breathing, lung crackles. They may even have a dry, hacking cough. And so that's just a reminder of the flow of blood through each sides of the heart. So like I said, there is electrical conduction that is inherent in the cardiac muscle cell, and that's what causes the atria and the ventricles to contract and to pump the blood out. And there's a normal pathway that it's supposed to take, and that's what this slide shows you. So this slide shows you the left and the right side of the heart, and it points out some key things for you to know. One is the SA node. That's where each heartbeat should begin. We also call that the natural pacemaker of the heart. That's where each heartbeat should be generated. And then it follows a path down the atria to the AV node. And once there, it kind of hangs out for a split second. And then it travels down the right and left bundle branches, and that's what causes the ventricles to contract. So this should be a specific sequence. It should take a predictable path, and it should take a certain amount of time. And those are all things that we can look at on an EKG strip. Now, that electrical conduction is dependent upon blood flow to the tissues, because in order for the electrical conduction to happen, you have to have healthy muscle. You have to have healthy cardiac cells. And so this is where I wanted to show you how the coronary blood vessels, specifically the coronary arteries, come into play. They are branched off the aorta and they perfuse the heart muscles. There's two main branches. You've got the right, the left, and then you've got what's called the circumflex. The right artery is important because if you think of what's in the right atria of the heart, that's where the SA node and the AV node is. And then the left coronary artery, the circumflex, those are important because those perfuse the left ventricle, which is our main or biggest pumping mechanism of the heart. So it's important to have good blood flow. And we're going to talk about this more in the next unit, but if a patient has coronary artery disease, what is happening is they have atherosclerosis building up in those arteries, diminishing blood flow and diminishing the perfusion ability. And when someone has a heart attack, you're actually cutting off blood flow to parts of the heart, and that's going to affect the electrical conduction and the pathway of electrical impulses, and that's why we can see an MI on an EKG strip. So just wanted to plant that seeds. So let's put the two together. Let's put the structure of the heart and the electrical conduction of the heart. It's dependent on healthy cells, good blood flow, and electrolyte balance. For example, potassium needs to be in a normal range. And so if you look at the heart diagram in the upper left corner, that shows you the SA node, the AV node, and then it travels down the ventricles to the right and left bundle branches. And so if you look on the blue part, you can see there's some waveforms. The first one is labeled atrial depolarization, and then there's an arrow, and it's labeled P. That is your P wave. That is the atrials contracting, or the atrium contracting. Then it travels to where you see the letter Q going up to R, down to S, and then back to baseline. That's your QRS complex. And if just below that it says ventricular depolarization. So those are the ventricles squeezing. And then the last letter that you want to focus your attention on is the T. That is that third bump, and that's ventricular repolarization. So that's the ventricular cells going back to a resting state so that we can do another heartbeat. So these three forms are what compose a single beat of the heart. And they should take a particular pattern, and it should take them a certain amount of time. So if you look at the slide, along the bottom axis, it says time, and that's in split seconds. So a normal P wave should take a certain amount of time, the QRS should take a certain amount of time, etc. The other thing that we want to think about is how different these bumps look. A P wave represents the atria, which are smaller than the ventricles, and that's why a P wave looks smaller than the QRS complex. Okay, let's look at that in a different way, just so you can see what I'm talking about in color. So this slide shows you that P wave, QRS, and T wave, but we've highlighted them in different colors so you can see exactly what each section represents. So with the first bump, all the green, that's your P wave. Then it returns to the gray, and the next thing is orange, red, and purple. Those three colors are the QRS complex. Then we return to gray, and then we've got the blue wave, that's your T wave. So remember, your P wave represents atrial depolarization. Your QRS represents ventricular depolarization. And your T wave equates to ventricular repolarization. Now, you're probably asking me, why can't we see when the atrias repolarize? And that's because it's hidden in the QRS. Because the ventricles are so much more powerful, you can't see the atrias repolarize. It happens, we just can't see it on the EKG waveform. Okay. So the other thing is, I told you that as you move along the line, it indicates time, and that's where we can take our EKG calipers and do some measurements and say, okay, how much time is it taking for it to go from the start of the P wave to the start of the orange or the Q wave? So we can measure that amount of time. And there's a normal range that we're going to talk about, but it's 0.12 to 0.20. So I think of it as 12 to 20 and put a period in front of those numbers. We also can measure how long it takes the QRS complex. And from there, you'd put your calipers on the orange to the purple and measure. And there's a normal range for that. And that is 10 or less, so 0.10 or less. And I would know these normal values. There's one more piece that we can look at, and we'll talk about this more next week, and that's the ST segment. If you notice, after each of these waveforms, it kind of goes back to a flat line. That gray is the flat line. That's the resting state where there's nothing going on. We also call that the isometric line. And when a person is having a heart attack, I told you that we can see that on an EKG. The ST segment is where we will typically see heart attack related changes on an EKG. What we will see is ST elevation, ST depression, or the T wave can be upside down. If you see any of those three things, those are a red flag and indicate that there may be cardiac muscle damage going on or a heart attack. So how do we do these EKGs? What we do is we hook the patient up. This picture represents a 12-lead EKG, but there's also 5-lead ones that we're going to talk about on the next slide. A 12-lead EKG, the biggest thing that staff nurses need to know is just have your patient lay as still as possible, because the EKG equipment will pick up movement, and that will it will be harder to read what's going on with the heart. So I mentioned there's the 5-lead. This is what you're probably more familiar with from your clinicals. Sometimes they're called telepacks or portable heart monitors. And there's 5 electrodes that stick to your patient in specific locations. And this is the way that a lot of places teach you to remember where they go. On the right side, it's air above grass, so white electrode above green. Ground is brown and it's in the middle. And then on the left side, it's smoke above fire, so black above red. So just a way to remember it. All right, now we need to talk. I told you that we can measure stuff in time because of the EKG paper. So let's take a closer look at each EKG paper. EKG paper is a specific type of graph paper where all the little boxes represent something. So if you take the smallest little box, it represents 0.04 seconds of time. So the cool thing is that if you get 5 of them, it represents 0.20 seconds. And then if you look at the strip, there are little marks along the top of the pink paper, and it says 3-second marks. This is cool because we want to read a 6-second strip, so we want 3 of those marks. We always read 6-second strips. It's just how it is done. And the nice thing about 6-second strips is that we can get a rough estimate of what is the heart rate by counting how many heartbeats are on the 6-second strip. So for example, on this one, if you count the complexes, we have 1, 2, 3, 4, 5, 6, 7. And because it's 6 seconds, we can multiply that by 10 to equal a minute. And so there's 7 of them times 10 equals 70 beats per minute. So it's really kind of neat how it's set up that way and how we can take our measurements. And so remember I told you how we would use the EKG calipers to measure the PRI or P to R interval, and then you can count the boxes. So your PRI interval or P to R interval should be 0.12 to 0.20. So we literally just measure and then count how many boxes. And we do the same thing for the QRS complex. Okay, so now let's talk about what it all needs to look like. Phew, excuse me. Sorry. What it all needs to look like to have an EKG be determined as normal sinus rhythm. So this is the recipe, if you will, or all these things have to be true in order for it to be normal sinus rhythm. So the first thing is the rate. We know a normal pulse is 60 to 100 beats per minute. So, and the sinus part comes from, I told you the SA node is sometimes called the pacemaker. It's also the sinoatrial node, and that's where the sinus comes from. Okay, so let's count how many PQRS T-wave complexes we have, and we're going to say this is a 6-second strip. So we're counting 1, 2, 3, 4, 5, 6, 7, 8 beats of the heart on this 6-second strip times 10 equals 80 beats per minute. So the rate is in between 60 and 100, so that's okay. Rhythm, it should be regular, meaning if you measure a P to P, it should be the same distance all the way across the screen. Then if you line up your QRSs and measure, those should be the same distance all the way across the screen. If both those things are true, the heart rate is regular. Next, we take a closer look at those P waves. Okay, do they all look alike? Are they all upright, meaning the bump goes up? And is there one of them to each QRS? So what I like to do is I like to look for my QRS because I know on the left side is going to be the P wave and on the right side is going to be the T wave. So then I can go, okay, there's one P wave, one QRS, one T wave. And then I can just follow that pattern to make sure it marches all the way across. So this is when we would do some measurements because the PRI needs to be between 0.12 and 0.20 to be defined as normal sinus rhythm. And then we have to measure the QRS, and that has to measure 10 or less in order for it to be true. So all of these things have to be true in order for this EKG to be labeled as normal sinus rhythm. So that's our baseline. That's what everything should look like, but unfortunately that's not what everything looks like. There are some variations that you need to be familiar with and be able to identify as a nurse. Now what I'm going to do is introduce you to the core rhythms that you need to know in order to be successful in term 6, 7, and pass your boards. So the first one I want to talk about is Sinus Brady. With Sinus Brady, everything is right, all the recipes correct except for one thing. The heart rate is less than 60. So if we count how many PQRS T-wave complexes are on this 6-second strip, there's 1, 2, 3, and 4. So we multiply that by 10, we get 40 beats per minute. Otherwise, everything else is correct. The only thing that's wrong is that the rate is too slow. It's less than 60. So if a patient is Sinus Brady, they may be tolerating it just fine. This could be normal for them. If they are very active and are extremely athletic, they may have a resting heart rate less than 60, and it just means that their heart doesn't need to go faster than that. But if they are hypotensive or symptomatic with bradycardia, we may need to treat it. And what we would turn to is atropine for the slow heart rate, and we may even consider giving epinephrine for the low blood pressure. So then we talk about the flip side of that. Okay, what if we've got sinus tachycardia? So the problem with this is it's just going too fast. It's greater than 100 beats per minute. So if you look at this, it's harder to read because everything's smushed together, because while it's a 6-second strip, it's going so much faster. There's so many more complexes on the screen. So what I like to do is try to find a QRS complex, and then, okay, I know right before it, it's got to be the P wave. Right after it, it's got to be the T wave. So then that's what I'm going to look at is, okay, are all the P waves the same distance apart all the way across the screen? Are the QRSs the same distance apart all the way across the 6-second strip? If both those things are true, it is regular. Next, I'm going to take a closer look at my P waves. Do they all look alike? Are they all pointing upwards? Are they upright? And is there one of them to each QRS? There is. Then I would get my calipers out and do my measurements, and the PRI should be 12 to 20 still, and the QRS should be 10 or less. So everything is right except for it's just going too fast. And again, this could be a normal finding. When we exercise, our heart rate goes into sinus tach, and that's to compensate for the increase in activity. And then when we rest, it returns to a normal rhythm, or excuse me, a normal rate. But if your patient is having tachycardia and complaints like chest pain, this would be a need to notify the healthcare provider. The other thing that comes along with this is that the idea is the faster the heart is beating, the less time there is to fill the heart. So you're not getting it filled quite as full as it would be if it was a slower rhythm. So there is that. Okay, so those are two variations. It could be sinus going too slow, sinus going too fast. Then we come to something's going wrong in the atriums. There's two of them. The first one we're going to talk about is atrial flutter. With atrial flutter, there are some key characteristics that make it easily identifiable. The P waves. They aren't true P waves. What they are sawtooth flutter waves. So if you look at the backside of a saw where you actually put to the wood, that's what these look like. That's the textbook characteristic of atrial flutter. And so if we break it down, we can't call this regular, because the P waves, there's more than one of them. That's irregular. But if you look at the QRSs, they are evenly spaced. And that's why we say this is regularly irregular. Part of it is regular, part of it is irregular. The other thing that you'll notice is if you look to your QRS, on the right side is your T wave, and then you have 1, 2, 3 sawtooth flutter waves, a QRS, a T wave. 1, 2, 3 sawtooth flutter waves, a QRS, a T wave. So there's no way for us to do our measurement for the PRI because there's more than one atrial wave, which is not correct. It shouldn't be like that. So we can't do that measurement. And the QRS, though, is going to be 10 or less. And that's because the problem isn't in the ventricles. The problem is in the atria. And there are various what we call conduction rates. So for this particular strip, there are 3 atrial contractions for 1 ventricular contraction. That's a conduction ratio. You could have 2 to 1, you could have 4 to 1. And this is where counting your atrial rate and your ventricle rate, you're going to come up with 2 different numbers. So let's start with the ventricle rate. If you count the number of QRS complexes on here, you will come up with 1, 2, 3, 4, 5, 6, 7. So if we multiply that by 10, the ventricles are contracting about 70 beats per minute. Contrast that with the atria. Because there's 3 flutter waves to each QRS, the atria are going 3 times as fast. So there's 3 atrial contractions, 1 ventricular contraction. So the atria are going roughly 210 beats per minute. So think about that and what sort of effect that could have on cardiac output and the sort of effect it could have on the heart's blood pooling and not getting pumped clean through, and then an increased risk for clots as well. So atrial flutter and atrial fib are very similar but look distinctly different. Let's talk atrial fibrillation. Atrial fibrillation is irregular. There's no P waves. Instead of any sort of P-like activity, it's just little bumps, chaotic little bumps. That's the fibrillation part. We do still have QRSs that look like QRSs because, again, the problem's in the atria, not the ventricles. But if we try to measure the distance from QRS to QRS, they're not regular. Some are closer together, some are farther apart. And that's why we say this rhythm is just straight up irregular. So we can't do our PRI measurement because there's no P waves. We can still do our QRS because the ventricles are behaving, they're contracting normally. So what's happening in atrial fibrillation is that there's an ectopic focus or an area that isn't the SA node that's irritated and trying to cause an electrical conduction. But not all of them go through to the ventricles. So it's kind of like a ball bouncing off the walls, and then every once in a while you'll throw it just right and it goes out a door. That door is the ventricles. So the atrium, because it's chaos, it's quivering. There's no smooth pumping, and so that dramatically affects cardiac output and allows for blood to be pooling. This is why we will treat atrial fibrillation with anti-arrhythmia medications like amiodarone or cardizem, and we will also use anticoagulants like heparin and Coumadin to ensure that there's no clots that are going to get pushed through and cause a problem such as a stroke. Okay. So those last 2 rhythms, atrial fib, atrial flutter, those have both been a problems in the atrium. Now we're going to talk about a problem in the ventricles. So PVCs, premature ventricular contractions, basically what happens is the ventricle gets a little too excited and pumps, contracts when it's not supposed to. So the reason why we say the rate varies upon the underlying rhythm is whatever their heart rhythm is. For example, on this slide, it's normal sinus rhythm. And then there's just the one PVC, and that PVC is the 3rd complex in. So what happens is, if you were to measure this out, you would see that the ventricular, the downward motion, that is a little bit early, and it's characteristically going to look like this. I called it wide, weird, and usually upside down. That's textbook premature ventricular contraction. And we don't get too excited about an occasional PVC. It can actually happen in some people just from exercising. Some people can have them with caffeine intake. When we worry about them is when you get a bunch in a row. Because of the fact that if it's a PVC, if that ventricular contraction jumps in too soon, the filling hasn't happened of the heart, so that's going to cause a decrease in cardiac output. But if you only have one, your body can if you have one PVC, your body can compensate. If there's a lot of them, we're going to try and treat it and to decrease the area in the ventricle that's irritated and jumping in when it shouldn't be. And so we could use something like lidocaine or amiodarone to treat this if they have a lot of them in a row. Electrolyte imbalances such as low magnesium can also cause these, or low potassium. And if that's the case, we would correct those imbalances. So we don't get too excited if it's just an occasional PVC. What we do get excited about and worried about as nurses is if you've got a few in a row. Because what happens is they can actually look like this. And this is a different arrhythmia. This is ventricular tachycardia, and this is a shockable rhythm. This is an emergency. If your patient has an EKG 6-second strip that looks like this, most likely your patient is not going to have a pulse. And if they do, they're going to lose it pretty quick. So this is an emergency rhythm. Ventricular tachycardia, if you look at this strip, there's no QRS complex that you can identify because the problem's in the ventricles. We know it's V tachycardia because there is a pattern there, but there's no QRSs. So I'm going to take a second and just contrast that with the next rhythm, which is ventricular fibrillation. This is also an emergency. Your patient isn't going to have a pulse with this one, but if you look at this, there's no QRSs. So we know the problem's in the ventricles, but there's also no pattern. We have just chaos. And when there's no pattern, it's fibrillation. So backing it up to V-tach, it has a pattern, but there's no QRSs. So we know the problem's in the ventricles. And basically the ventricles are just running the show. And they're going too fast, and we're not getting any sort of cardiac filling. So they're really not going to have a pulse. And again, this is a shockable rhythm. And what could cause this to happen? There's a variety of things. People could have a coronary event, such as a heart attack. They could have an acid-base imbalance, or illicit drugs can also do this to a client. We're going to defibrillate them. And just remember, always remember, guys, when a defibrillator is going to be run, don't touch the patient or the bed because that electrical charge could actually go through you. So again, our second shockable rhythm is ventricular fibrillation. They're not going to have a pulse. The heart muscle is just quivering. No cardiac output whatsoever. And that brings us to the end of the core rhythms that you need to know and that are in your textbook. The next topic I want to touch on is not in your textbook, but you do need to know this information for your boards, and you will get this information again in Term 7. So what I have on this slide is a poem. This is the heart block poem, and it helps you remember the different types of heart block. And heart blocks just mean that the SA node and the AV node, one of those two or both of them are not working properly. So the impulse isn't being generated as it's supposed to. So here's the heart block poem. If the R is far from the P, then you have a first degree. Longer and longer, drop, then you have a winky Bach. If some P's don't get through, then you have Mobitz 2. And if your P's and Q's don't agree, then you have a third degree. And let's look at these a little closer. Okay, so the first one is a first degree block. Remember we've talked about that measurement, that PRI? That's what this refers to. The PRI is greater than 0.20. Usually this is well tolerated. We could treat it if they're severely bradycardic, but usually we just monitor it. The second degree block is also called winky Bach. That's why I've got that written off to the side. With that one, your PRI is getting wider and wider, and then a QRS just doesn't show up. So that's a little bit more serious because now we've lost some ventricle. But again, usually that one's pretty well tolerated. The second degree Mobitz, this one, the PRI interval is regular, but QRSs are dropped. So this is a more serious one because more QRSs are more frequently affected. So that decreases cardiac output to a more significant degree. So usually these people are going to have a pacemaker placed. And then the third complete block, or excuse me, the third degree block is sometimes called a complete block because the atria and the ventricles are totally not working together. You could have a P wave and then like way far away a QRS followed by another P wave, you could have a couple of QRSs. These people are going to have very low cardiac output. We're going to use atropine, emergency drugs like dopamine, epinephrine. We're going to do a temporary cardiac pacemaker until we get a permanent one placed. So those are the key types of heart blocks and the way we tell them apart. The other thing with heart blocks, specifically if they require a pacemaker, is when we read an EKG strip, we have to look to make sure that pacemaker is firing appropriately and causing the heart to pump in a coordinated manner. And what we're going to look for are those pacing spikes. So it's a spike because it's electrical activity that's triggered by the artificial pacemaker surgically implanted into the patient. And those red arrows indicate the pacer spike. They're followed by a QRS and some sort of T wave. It's going to look different depending on the patient's heart and the amount of damage that happened prior to the pacemaker being placed. So that's very important to remember. And then lastly, I know this is so much information. Just remember that you can do this. Listen to this recording as many times as it takes for things to kind of click. Let me know if you have any questions. And I will see you in class, and shoot me an email if there's anything else I can do to help.